Hello. Good evening, friends, and welcome back to the Thursday evening PG teaching session brought to you from Sion Hospital, Mumbai. We thank the authorities at Sion Hospital for allowing us to conduct these classes here, and we thank Aristo Pharma for an educational grant which allows the live webcast of these classes. Today we have two cases again. The first case is being presented by Dr. Srihari from Sion Hospital.
Good evening, everyone. This is Dr. Shriri, third year resident from Sion Hospital. 8-year male child, third by birth order, born out of third degree consanguineous marriage, residents of Ghatkopar, Muslim by religion, Sheikh by community, with mother as informant, comes with a complaint of diplopia since morning and nasal twang in speech since morning. Patient was alright before going to bed last night. Then in the morning, the child complained of diplopia when seen from both eyes and disappears when seen with one eye closed. Then the parents noticed medial deviation of the left eye and double image formed on the right side of the actual image and not associated with deviation or head tilt. Parents also noticed nasal twang in the child's voice since morning, not associated with any nasal regurgitation on the first day, not associated with any other focal deficit, and got admitted at our center. Next day, child developed medial deviation of the right eye and nasal twang increase associated with nasal regurgitation of the liquid diet and developed headache, frontal dull aching, aggravated on watching phone and relieved with sleep. On fifth day, the child complained of not able to blow wind and smile, and parents noticed that the child could not close the eyelids completely while sleeping and also noticed drooping of the eyelids on both sides. There is no history of weakness or other focal deficits. No history suggestive of any other cranial nerve involvement like loss of taste, smell, deviation of tongue, dysarthria, dysphagia. No history of loss of abnormal perception, loss or abnormal perception of sensations. No history suggestive of cerebral involvement in the form of nystagmus, swaying while walking, or vertigo. No history of bowel and bladder disturbances. No history of fever, neck pain, altered sensorium, seizures. No past history of similar complaints. No history of TB contact. No history of recent episode of fever, drug intake, vaccination. No history of constipation, cold intolerance, lethargy. There is a family history of early stroke in father at 21 years of age due to hypertension. Antenatal history, registered pregnancy, and every supplements were taken, and all the ANC scans were told to be normal. Fetal movements were perceived well, and weight gain was adequate, and it was uneventful. Natal history, it was a full-term normal vaginal delivery. Baby cried immediately after birth. Birth weight was 3.2 kilos, and not uneventful. Discharge on day of life 1. Immunization history, taken all the vaccines up to 1.5 years of age, up to as per national immunization schedule. Developmental history, the child has attained all the age appropriate milestones and par with the peers of similar age groups. And diet history, takes from the family pot, all the food groups involved, insufficient amount of calorie and proteins. Family history, second child expired at 2.5 months of age due to bilateral pneumonia, and the father has history of hemiplegia at 21 years of age associated with high BP, currently on antihypertensives and antiplatelet drugs, power improved with physiotherapy. Then according to the modified Kupusomi classification, the child belongs to lower socioeconomic class. Summary, this is
So what would be your thoughts when the first complaint came in? He got up in the morning and he had diplopia. So what would be your thoughts?
So means it's a history of an acute onset cranial nerve involvement, because the complaints are since morning, and like before the child went to the bed last night, he didn't have any complaint. So means anything acute, this acute could be maybe vasculitic or inflammatory.
I agree that we'll discuss the acuteness later, but what does that diplopia mean to you? It means a cranial nerve palsy. Can it mean anything else, or it's always a cranial nerve palsy?
So it is a binocular diplopia.
Sorry?
Since it is a binocular diplopia, since the child
Binocular was later, no? First it was...
No, but the child could see complaints of diplopia only when seen from both eyes.
Okay.
And not from individual eyes.
Okay.
Then it is suggestive of some cranial nerve palsy and not the ophthalmic cause of diplopia.
Okay, so what are the ophthalmic causes of diplopia?
Subluxation of lens or corneal aberrations or something. Any structural abnormalities within the eye can cause diplopia, basically.
Okay. So when you say that when you cover one eye and the diplopia disappears, how does that help you decide that this is a cranial nerve palsy?
Since when the alignment of the vision is not proper, the child is getting diplopia when seen from both eyes. With individual eyes, the formation of image in the single eye is proper and the child is not having any diplopia at that time. Only when seen from both eyes, the child is having this thing.
No, agreed. What I'm trying to ask is, imagine for a minute that the diplopia is due to subluxation of lens in my left eye. Okay. Now, when you close the left eye, what will happen? I am seeing only with the right eye. So, will I get one image or two images? One image. So, there is no question of diplopia. Now, when I close the right eye and I am looking with the eye where the lens is subluxated, then will I get one image or two images?
Two images. In two images. When the affected eye is seen, when the affected the eye with subluxation is with which we see the, if we see the object, then diplopia occurs. That is uniocular diplopia will occur.
Okay. Okay, go ahead.
Then parents noticed medial deviation of the left eye and double image formed on the right side of the actual image. The child complained of right. Basically, there was a convergent kind of squint. The child could see the left eye was the one which was deviated actually, and the child could see the image on the right side of the image, and that was not associated with any head tilt or deviation. Then parents also noticed.
So what do you mean by not associated with head tilt or deviation?
Usually, if it is if the brain cannot handle the double image formation, then the brain compensates it by tilting the head.
Does it happen acutely? It will be a chronic compensation. So once this problem remains for a while, then that child will achieve that kind of a compensation. Right? Okay. So now we come to the possible reason for this. So you said acute. It's acute. So what could be the possible reason?
Any infection or
so which nerve do you think is affected?
Since there is a medial deviation of the left eye, then left lateral rectus is the probable one which is affected. Which is sixth nerve. Usually.
Correct. So sixth nerve. So now what is the possible reason for this sixth nerve?
Sixth nerve has the longest intracranial course. So in any case of raised intracranial tension, any tumors, any raised intracranial pressure will first affect the sixth nerve.
Very good. So in this case, do you think it is that?
It could be at this point of time. Our suspicion could have that there could be some raised intracranial tension and the child might be having.
And the first manifestation of that raised intracranial tension is the sixth nerve in this child.
Probably it is the slow onset increase in tension. It's a chronic disease which is presenting acutely, which has the first component, that's the intracranial space occupying lesion, which presenting first time with this kind of presentation.
Any thoughts on that? You got the question. I am asking that can it be that the first manifestation of raised ICP is the sixth nerve itself? So it is less likely. I mean, once in a blue moon it may happen, but at least for discussion's sake and for normal understanding, you would expect maybe they will not come with that complaint. They may not have complained with the headache, vomiting. But at this point, if you ask for the history, whether he was bang normal or whether there was some headache, vomiting prior to this, logically you should get some history. Okay? Fine. Then next, any other possibilities besides raised ICP?
Yeah.
Acute bleeding manifestation, a large intracranial bleed.
What I mean is, what is the mechanism of a large intracranial bleed causing a sixth nerve palsy? Raised ICP. And being acute, there has to be severe headache along with it. Na? If it's a acute intracranial bleed, there has to be a severe headache along with it. Okay? What else?
Any infective vasculitic causes like TB vasculitic cause, then demyelinating causes, inflammatory causes could be.
Okay. Fine. Now the next manifestation is what?
Next day, on the same day, parents also noticed nasal twang in the child's voice since morning. That was not associated nasal regurgitation on the first day, and there was no other focal deficits on the first day. But next day, the child developed medial deviation of the right eye also, and nasal twang increased, and associated with nasal regurgitation of the liquid diet, and developed headache, frontal, dull aching, aggravated on watching phone, and relieved with sleep.
Okay. Dr. Mahesh Mohite is saying that since the child got up with the deviation of the eye, the onset can be any time overnight, so it may not be hyperacute. But yeah, I mean, I get your point, Mahesh, but we may have to, there may not be a big difference between that. Okay. So what does this nasal twang mean?
Involvement of the 9th, 10th cranial nerve.
Okay. Why 9th, 10th cranial nerve?
Which helps in swallowing and the affection which is causing regurgitation of the fits.
They supply soft palate, so involvement will cause nasal twang.
So along with the nasal twang, there should be any difficulty in swallowing and all, which is not there.
On the first day it was not there. From the second day, the nasal regurgitation, the child developed nasal regurgitation for liquid diet.
Okay.
And also developed headache.
Okay. So now what are your thoughts at this stage? Which are the nerves that you think are getting involved?
Here initially there was a unilateral sixth nerve involvement, then it became bilateral sixth nerve as per history, and then involved.
Okay, so the moment it is bilateral sixth nerve, how will your thought process go? So is it still raised ICP or is it something else now?
It could be raised ICP also. If it is not if the tension is if it is a chronic condition, chronic intracranial space occupying lesion affecting the whole cranium equally, it's because of the pressure it is affecting.
So I personally think that if both sides you have a sixth nerve and yet nothing to suggest primarily raised ICP, it's too much to have both sides sixth nerve and no original symptoms of raised ICP. Okay. So the moment the second one, even the first one, we said that there should be some symptoms, but the moment the second one comes in, raised ICP seems a little less likely. Next. Next means, what is your next thought process? After that, what happened? Bilateral sixth and then?
Then child developed nasal twang, which and regurgitation of the feet, which is the involvement of the 9th and 10th glossopharyngeal and vagus nerves.
So now what is your thought process with this? Now that 9th and 10th are coming in. Means I want you to make one or two observations. So what do we first do when we are taking the history? What is our first step? Localization, anatomical localization. So now, and tell me, what is your thought about anatomical localization?
Involvement of the lower cranial nerves is taking place 9, 10, and initially we had the 6th nerve involvement, so maybe some brainstem related lesion.
Okay, brainstem related lesion, but try to go a little more. So where is the sixth nerve situated? Nucleus of the sixth nerve? Which part? Pons. Then seventh?
Pons.
Pons. So eighth? Pontomedullary junction. Then ninth and tenth?
Medulla.
Medulla. So you have something in the pons, you have something in the medulla. In between you have a kind of a skip. So what I'm trying to say is, suppose this is a CP angle tumor. Is it possible with this kind of a nerve distribution?
For CP angle tumor, it will take long time to involve each nerve turn by turn, and this seems some multifocal lesion, some inflammatory or.
So what I am saying is that you start thinking that possibly this is not one structural thing which is involving the sixth as well as the ninth, tenth, but some other pathology which can involve different cranial nerves, because in between there is nothing, and the distance to be covered structurally will become bigger if you are taking from the sixth nucleus down to the ninth, tenth nucleus, right?
Yes.
Okay, Dr. Mahesh Moite is asking, is it UMN or LMN? So can you make out on the history?
Based on the history, we cannot, since only on checking gag we can say whether there was increased gag or.
Speak clearly.
Based on the history here, since the involvement of 9th and 10th can be tested only on testing gag reflex, whether it is increased or decreased. If it is increased, then it could be UMN lesion, and decreased, then it is LMN lesion. On the
Correct.
history basis, he cannot.
So on history it is difficult to say whether 9th, 10th is UMN or LMN. Okay, fine.
Then on the 5th day of the illness, the the parents noticed the child could not blow and smile, and parents noticed the child could not close the eyelids completely while sleeping, and also noticed drooping of the lids on both sides.
So now what does this mean?
It's involvement of the 7th nerve and also 3rd nerve.
7th and 3rd
So
on one side or both sides?
both sides.
Okay. So now what are your thoughts now? What could be the reason behind this?
Since it is not affecting all the cranial nerves at the same time, and there is a patchy involvement, it could be some inflammatory thing, or the likelihood the intracranial space occupying lesion is less likely, since it is not.
Yeah, so now space occupying lesion is almost ruled out. So we said in the beginning, but now it is almost ruled out because of so many widespread involvement, right? Is there any fever?
No extra fever.
Yeah. So Dr. Moite is saying that nasal twang and regurgitations usually suggest hypotonia, so more likely LMN. Okay?
No.
Fine. Then
No history of other weaknesses or focal deficits, and no history suggestive of other cranial nerve involvement like loss of taste and smell, deviation of tongue, dysarthria, dysphagia. Then no history of loss or abnormal perception of sensations, and no history of cerebellar involvement like swaying while walking, vertigo. No history of bowel and bladder disturbances. No history of fever, neck pain, altered sensorium, seizures. No past history of similar complaints. No history of TB contact. No history of recent episode of fever, drug intake or vaccination. No history of constipation, cold intolerance, lethargy.
why did you ask that?
For hypothyroidism.
So how is it related?
Usually in hypothyroidism there will be myxomoid tissue development, and there will be some kind of raised ICP kind of sense.
Yeah, but we already discussed that raised ICP is now ruled out, right? So this, I feel this negative history doesn't fit in here. So you should avoid this, right?
And there is a family history of early stroke in father at 21 years of age due to hypertension present.
So any thoughts on that?
There is a significant family history of stroke in young.
So stroke in a young person would mean what?
There could be metabolic syndromes associated. There could be intracerebral malformations, congenital malformations.
And you said he had hypertension. So what would
Hypertension.
that tell you? What kind of hypertension is this?
Second.
So you have to start thinking of secondary hypertension, and then again whether the cause could be related, secondary hypertension, because it's too young a age to cause primary hypertension, right?
Yes.
Okay.
Sixth nerve palsy, and suddenly, at that time one does not know what exactly is happening, but when there's a lower nerve involvement, peripheral nerve involvement, you always think of lower motor neuron. And on the other side, when it occurs, your suspicion grows even stronger. And in such a short time, even the third is involved. The chances that there's something inflammatory going on and central nervous system raised quite. By the time so many things are involved one after the other, some manifestations of raised intracranial pressure may have come, because if you look at it as a false localizing sign, then also if it is coming one after the other, some raised ICT must have come. And so you start thinking of something affecting peripheral nerve, mostly one after the other, some inflammatory cause. When ocular movements are involved, one always thinks at the back of our mind whether it's myasthenia. But the history is everything has occurred in the morning, while myasthenia, all the problems will be worse in the evening. So among the lower motor neuron, I think is peripheral nerve, and the nerve nuclei are quite separated, left one and the right one, and then so there is less likelihood of one lesion producing that unsynutic or false localizing. And when the seventh is also involved, and then the ninth and 10th, false localizing is out. So something which is involving peripheral nerves by one after the other, the seventh, then the ninth, and now we have to see how it is proceeding. There is no past history of anything. I am not able to connect the hypertension in the father with this. Even if he had, suppose, unusual case of childhood hypertension, there have been other manifestations much earlier than neurology. So I think we boil down to lower motor neuron type, coming one after the other. So acute or subacute development started with acute and developed over a short time, and therefore most probably inflammatory. Let's see what is the further progress. And there has been no hemiparesis or anything on the side, so that problem doesn't arise. So what I expect now is some other involvement now of cranial nerves, or maybe upper limb involvement or lower limb involvement or something like that in time to come. Let's see what it is.
Then birth and developmentally the child is normal. And the summary, it is a 8-year male child, third by birth order, born of third degree consanguineous marriage, with complaints of sudden onset progressive cranial nerve palsies with no other focal deficits and no symptoms of raised intracranial tension, with a family history of hemiparesis of young in father. In a birth and developmentally normal child is probably a case of inflammatory like ADEM or multiple sclerosis, or then polynetis cranialis, then intracranial space occupying lesion. It could be TB, vasculitis, or any inflammatory conditions like sarcoidosis affecting, or metabolic could be because of vasculopathy.
So I guess you have listed the various causes of multiple cranial nerve palsies, but can you discuss and debate each one? Let's go from the bottom up. So what about metabolic vasculopathy?
Since the child, there is a family history of hypertension and hemiparesis in the father, There could be in a well-grown child. There could be in a well-grown child. There could be a possibility of vasculopathic changes and small stroke in the cranial.
There's no history of any deficit or hemiparesis for the vasculopathy to cause chronic ischemia stroke. There is no neurodeficit. So that would not be in favor of metabolic.
There could be pinpoint strokes. There could be small strokes which can affect certain areas. Like certain areas can be affected, like the small artery strokes.
So I get your point. My thought process is that this is too too difficult to digest, that there are 5 or 6 pinpoint strokes only affecting the cranial nerves, right?
Yes.
That is very difficult to digest. So therefore, I wouldn't keep that as a differential. Then what about sarcoidosis?
Is one of the common inflammatory condition of the intracranial, which is known to affect which is known to manifest in this form with multiple cranial disseminated in space-time like features.
Yeah, but that's the point, no? Disseminated in space and time. What is the story here? All this has happened in a matter of days, right? So that I feel is against sarcoidosis. Sarcoidosis is a longer process than just a matter of days, right? So you will not put that as a DD. Then infection, TB, vasculitis. What are your thoughts?
Vasculitis will not involve only cranial nerves.
Also, a contact and a well-grown child should not directly develop TB, CNS TB.
Okay, so that also means so the whole point is that because there are so many multiple areas involved, and as Sir pointed out that it is not necessary that all those nuclei are getting involved at different areas. It's very difficult to get selective nuclear involvement in so many different areas. And therefore it is the nerves which are getting involved, which means it's likely a demyelination process which is affecting the nerves rather than any vasculitis or infarct, right? Yeah. SOL, we have already discussed that it's less likely, right? So possibly I would say that you put only the first and the second as a DD. Now what is this polyneuritis cranialis?
Polyneuritis cranialis is a variant of GBS which only affects cranial nerves actually.
Correct. So we are thinking basically of either a variant of GBS or some such thing, a demyelinating process. That is the only thing that kind of fits in. Now, to call it ADEM, I mean, yeah, it's possible, but what is preventing you from calling it ADEM?
No other deficits and
so there is no E and no M yet. So there is no E, there is no enkephalon involvement, and there is no behavior change, no cortical symptoms at all, nor is there a M, right? So that's the difficulty of calling it ADEM, right? Fine. What about multiple sclerosis in children? What are our thoughts on that?
Even that will be disseminated in space and time.
And the lesions are white matter and only spine.
Spine involvement is
spine is almost the hallmark of multiple sclerosis, right? So therefore, you would rather narrow down from all this to say, ADEM, which is, further manifestations will come. Otherwise, you are looking at a demyelination process, a variant of GBS types, right? Okay. Sir, anything?
So one etiology we have not mentioned for or against is toxin mediated. That can also come as an acute onset neurodeficit affecting cranial nerves. So
Example.
snake bite or botulism.
So tell me what is against that. So you're right, good thinking. I thought again it is multiple cranial nerves, but in one area of the body only. So when you think of a toxin related cause, the toxin cannot be limited to one area of the body. The toxin has to affect the whole body. So like a polyneuropathy kind of a picture, yeah, multiple areas of the body involved, yes, right? But when it starts getting involving only one area, then you again go away from the toxin as a process. But good point to make, yeah?
Yes.
Okay, sure.
One toxin mediated, though it's not applicable, we used to see diphtheria once upon a time. And after the patient has recovered from diphtheria post diphtheritic polyneuritis, there was a sequence. Definitely, the palatal palsy will come up first, followed by other cranial and followed by polyneuropathy. So a toxic and something which has happened 2 to 3 weeks. This was a 3-week complication which will begin later on. So this is what we can think of. It was a good suggestion. We'll keep that in mind.
In examination, the child was vitally stable. Pulse rate was 100 beats per minute. Regular rhythm, normal volume. Respiratory rate is 28 cycles per minute. Abdominal thoracic respiration. BP was a little higher side at 90 to 95th centile, and sugars was maintained. Then anthropometrically the child was normal. There was no paler icterus, clubbing, lymphadenopathy or edema.
Okay, wait, child is here now. We'll just examine the child. I was expecting a riot here. I was expecting all of you to fight that I will examine, because you will never get this again. Chalo, 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 come. Start fighting and come. Chal, come. Namrata, come. Chal, who else is coming? Yeah.
You all saw him coming walking. You want to see him again coming walking, or that was enough for you?
निकाल के चलेंगे.
आपके क्रॉक्स निकाल के रखिए.
चलिए.
You want to see him walking? Very good. Badhiya. As a part of seeing a gait which may not be applicable, you ask him to do that. Then second is to ask him to do heel walking, to find out whether there is weakness of the dorsiflexor. Then ask him to do the toe walking to see whether there is a weakness of that. And then tandem walk to see for whether there is any cerebellar function. This should occur as a routine. And to add to that, I tell them to do that. And if he is able to do that, all the lower limb problems are all ruled out. So in one gait sitting, you are ruled out too many things. Okay? आपको ऐसे चलने को होगा. हाँ करिए, गिरना नहीं भैया. शाबाश. अच्छा टर्न करिए. Even when walking that time he could turn well. Now to there is no question. Movements of the hands when he walked that time were normal. So gait is normal. You are ruled out so many things. वहाँ खड़े रहिए. नाम क्या है आपका? जोर से बोलो, उधर सुनने को जाना चाहिए. अमन. शाबाश. अमन. Any conclusion drawn?
Nasal twang decreased.
है? In his name only M and N is there. That is the difficulty.
Means because you have been given that history, it's okay, but otherwise it's not like a very
sir,
prominent nasal tone.
लीलावती बोलो, लीलावती. Bolo, Leelavati.
He had severe nasal twang, sir. No one could understand what he was speaking before, actually.
But it has improved.
Yeah, it is improved now.
Almost normally speak,
Yeah.
where there was no M and N in it.
So now this is what you have to be careful in exams. Because exams when they are supervisors, they tell you he is a child with nasal twang. And his nasal twang has gone. In the exam you present it as nasal twang and examiner tells you come next time. Make him sit here. Yes. So Dr. Mahesh has added that botulism and snake would be progressive and descending. So like we said, he added that it will go down and involve other areas. Yeah.
Child is stable, well looking. He is conscious, oriented to time, place, and person. There, on head to toe examination, there is bilateral medial deviation of the eyeballs.
Before that, you should also talk about growth, sickness. So growth is good. You said well looking, yeah. And growth is good, right? Yeah.
And the gait was normal. There is no other obvious cranial nerve deficit visible. Like we'll
No,
examine
other
him.
means what is visible, first say that and then.
There is bilateral medial deviation of the eyes, so there is there could be bilateral lateral rectus involvement.
So this is just so you want to tell him to do something and confirm without touching him whether this is lateral rectus or no.
We'll check the eye movements, extraocular muscle movement. फिंगर को देखना है और जहाँ मूव करती हूँ उधर देखना है, okay?
No, so what other thing you have to do when you are checking?
To hold his hand.
Correct. So you can give the mic to him.
Bilaterally, he's not able to look to the sides.
That's all. Other movements are normal. So you have to do it a little slower and little more in range to confirm, no? Because you are now looking at extraocular abnormality, movement abnormality, so you have to confirm whether any other is also involved, right? Okay. Do it again. First do your lateral movements, no?
The oblique movements are also affected, and even the upward gaze.
Okay. Fine. Then
The other cranial nerve.
yeah, so look for the others. How will you look for third?
Third was the extraocular movements, and
What are the other components of the third?
the pupillary reaction.
And ptosis, no?
Yes.
So does he have ptosis?
No, he doesn't have ptosis. Then the sensations for the fifth cranial
Check the pupils. You want the mobile torch?
It's reacting normally. Direct and consensual light reflex are normal.
Okay.
Then the fifth cranial nerve.
When do you see consensual light reflex? If I see the direct pupil reflex is present here, and if I see direct pupillary reflex is present here, so this afferent and efferent is normal, this afferent and efferent is also normal. Then you don't want to see consensual reflex, where you want to see, you find that this is abnormal on one side, while this is normal, then you want to see when this is abnormal, whether it's the afferent path or efferent path which is abnormal. So you shine the light here, and this does not come up, then maybe the afferent path, then you shine it on this side and it comes up, then you know that efferent path is okay, but afferent path. But when you do direct reflex and present independently seen on either side, then there may be no need to do consensual light reflex. It's not wrong that you did it, but
Yes. Then for the fifth cranial nerve, we'll see the sensations on either side and the jaw jerk.
And the muscular part,
For muscles of mastication.
check.
Can feel the
Then
then the seventh cranial nerve.
do it.
did you see orbicularis oculis on both the sides? Did you ask him to squeeze the eye tightly? And I don't, I'm sorry.
अपनी आँख टाइटली बंद करना है, मैं खोलने की कोशिश करूँगी लेकिन खोलना नहीं है, ठीक है? जितना जो weak है,
आप उसको करके बताओ। ऐसा करो, मेरी तरफ देखो, ऐसा करो, बिल्कुल खोलने को नहीं, ऐसा जोर से करो।
बस आँख टाइटली बंद कर, मैं खोलने की कोशिश करूँगी तो मैं खोलने नहीं है।
One side or both sides?
Both sides it's weak.
Okay. Then
ऊपर देखो ऐसे, देख ऐसे ऊपर।
you should show him a finger or something, and also keep a hand on his head so that he doesn't go like this. Do it.
So the creases are not visible on the forehead. अभी so this will also
Mic.
ऐसा करो, ऐसा करो, हाँ, ऐसा करो, ऐसा करो, गुस्सा आता है वैसे करो. So you see the horizontal and the vertical crease. Also, it's a good idea to show what you want to, so that he understands easily.
अभी दांत दिखाओ.
What do you observe?
This side it's less.
So the right nasolabial fold is marginally less prominent than the left side. But what did you do when you asked him to puff his cheeks? What happened?
Both the sides were weak. Both the sides were weak. Sir.
Okay. So this is what now? What have you concluded from this examination?
So bilateral facial nerve palsy, element type.
Okay. So two things here. Is it palsy or paresis?
Paresis.
Why is that important? Because when it is bilateral facial nerve palsy, UMN and LMN becomes difficult to distinguish, right? Bilateral facial, if it is bilateral, then your distinction between UMN and LMN is gone, except for not frowning. You got my point? Why do you get the upper half of the face preserved in UMN palsy?
Bilateral supplement.
because of bilateral innervation. Now you got bilateral palsy. So bilateral innervation is knocked off. So bilateral UMN will also have both sides of the face completely unable to show any movement of the muscles, and bilateral LMN will also show the same. How do you differentiate? So LMN is kind of end result. So LMN there will be complete paralysis. In UMN bilateral, emotional fibers are intact. So if he has to show some emotion, then the face movement is possible. So that is the theoretical way to differentiate between bilateral UMN and bilateral LMN.
And
Okay.
also UMN will have,
Of course, the accompanying features of a hemiparesis and all that.
just
Right.
wanted to do one. देखो भैया, इससे बता, इससे जोर से, ऐसे ही दांत बताओ, और जोर से बताओ, और जोर से. To make it more obvious. अभी ऐसे करो, हवा बाहर नहीं आना, छोड़ना नहीं हवा, मैं दबा रहा हूँ, जोर से करो, ऐसा देखो, जोर से. It's very weak. So try and so to say, ask him to get it done this way. Okay.
Okay, so in exam when you have this case, you will not just say bilateral facial, you will say paresis because it's not complete weakness, and LMN or UMN?
LMN.
LMN. Okay. Fine, go ahead.
Then the eighth cranial nerve, for like he's able to hear and follow the commands, but we'll have to do René's and Weber's.
Okay. Then
For 9th and 10th, we'll check the gag.
before that you want to just inspect his mouth.
Position of the uvula has to be seen.
So what are you seeing when he is doing At that instant, what are you seeing? The movement of the palate also. The palate also goes up. So is it going up when he is doing So what would you have expected? You would have expected it to go up because there is absolutely no drooling and this. So he is able to swallow his saliva. So whatever had happened has possibly recovered. Right? Okay. Then
Spinal accessory.
as sir said, first you should show everything. Yeah.
मैडम दबाएंगे उसके बाद वैसे करना ठीक है मैं बताऊंगा मैडम दबाएंगे
12th.
Again the position of the tongue. जी बाहर निकाल. Center is not related.
You did not check one muscle supplied by 7th nerve.
Stapedial. Ask him to step.
Okay. Fine. Good. Come. Now tell us what else is there in your findings.
Anything elsewhere? Limbs?
No, sir. No other.
All normal.
No other focal deposits. Higher mental functions maintained. Then on cranial nerve examination, olfactory is present. Olfactory is normal, and optic nerve is also all the visual acuity is 6/6. Color vision is normal. Field of vision is also normal, and light reflex, accommodation reflex present. Then on primary gaze is esotropia and conjugate movements abduction defect present, and he could not do the he could not see upward when an outward, since he cannot do the outward movements, so he cannot see, he cannot, in an outward divided eye, it is recti which are the superiors and elevators and depressors. Since he cannot see outward, that movement is also suppressed actually. He cannot see laterally and see up and down in the lateral position of it. Then pupils are mid-dilated and symmetrical, light reflex reactive. Then LPS, there was mild ptosis. And trigeminal nerve sensation over the face normal, mastication, clenching of the teeth normal, jaw jerk normal. Then facial nerve forward frowning was reduced, eye closure lag of thalmus was present, and blowing of cheek was reduced. There was weak teeth showing was weak bilaterally, and there was no deviation of angle of mouth. And nasolabial folds were lost bilaterally. Taste sensation over the anterior two-thirds of tongue was normal. Then auditory nerve is Renes, it is air conduction more than bone conduction, and Weber's was centralized. 9th and 10th, gag was normal, and position of uvula was central, and taste over the posterior two-thirds of the tongue is also normal. Spinal accessory were normal, and hypoglossal nerve, there was no deviation of tongue and no tongue fasciculations. Then motor system examination were within normal limits, motor and sensory nervous system examination. There was no ataxia, tremors, no cerebellar abnormalities, no meningeal signs. Straight leg raising test was negative. Impression. 8-year male child, third by birth order, born of third-degree consanguineous marriage, with sudden onset progressive cranial nerve paralysis of third, sixth, seventh, with the ninth and 10th, with no other focal deficits and no symptoms of raised intracranial tension. And there is raised blood pressure with family history of hemiparesis of young in father in a birth and developmental normal child. Is probably a case of polyarteritis cranialis or inflammatory like ADEM. And since the hypertension is there, it could be metabolic vasculopathy also. I kept it as a.
Okay. Now I think, means for exam sake I am saying here your summary should be a little modified, as in you should say with history suggestive of sudden onset, progressive cranial nerve, 3rd, 6th, 7th, 9th, 10th. But on examination just now what did you get?
6th and 7th.
Only 6th and 7th, right? You didn't get 3rd and you didn't get 9th, 10th also just now on examination. So that you have to make a specific, yeah? Okay. Now, Dr. Mahesh Mohite is asking, can you clinically say visual acuity 6/6?
Visual, not on the, without Snellen's chart it is not possible. Without Snellen's chart.
Correct. So you have to do it on a Snellen's chart, right? And he asked earlier that nasal twang recovers but squint persists. Why? So Mahesh, is there a reason that you have in mind, or you are asking in general? Please write in the chat box.
Even the squint has reduced. Even the child, the diplopia complaints is also decreased. Initially, the child had severe headache because of the diplopia. Now everything has reduced. Initially, he required patching of the eye for the same. He could not see. He was getting headache, and now the symptoms has reduced. There is improvement.
Yeah. So means the other cranial nerves have recovered, and this is recovering.
Recovering phase.
Yeah. Okay. Fine.
And then these were the clinical photos.
Yeah.
He had ptosis also in this picture, and.
Okay. Investigations, what have you done?
The peripheral NCV study was normal, and MRI brain and angiography was also normal. But the NCV and EMG of the cranial nerve suggested of demyelinating type of neuropathy of facial nerve and the 9th nerve. Then there on CSF study there was a albuminocytological dissociation with there were 5 lymphocytes and protein was 132. And we had also sent antibody panel for the same, since in polyarteritis cranialis it is more specific for GT1A type of antibodies, anti-ganglioside antibodies, to confirm the diagnosis. But since we had already given the child IVIG, that came out to be negative.
Okay. Mahesh is asking which metabolic vasculopathy comes with hypertension. Do you know of any specific?
As any hypercholesterolemia, hypertriglyceridemia can cause, then hypercholesterolemia, hypertriglyceridemia, and it's like chronic condition, like
Can-
atherosclerosis.
Okay.
But the child had normal triglyceride and cholesterol levels,
Okay.
and sugar was also maintained.
Okay.
90 to 95th centile.
Yeah. Age or height?
Height.
Okay. Now, what is your understanding of this cytoalbuminous dissociation? Means, as a concept, what does it mean, and then what does it signify? Come on. What do you think?
It is not not infective cause. So, there is it is usually in GBS there will be high proteins and less cells.
Correct. So what I'm trying to say is, first of all, what is the cytoalbuminous dissociation? That there is a raise in protein which typically or classically is associated with raised cells also, as is seen in any inflammatory process, like in infection. Now here cells are not raised, but still there is a raise in protein. So this is a process which is typical of other demyelinating processes also. GBS, we learnt it first in GBS, but it is there seen in other conditions also, right? And in GBS, what is the timing? When do you see it?
Usually in
Second week
second
or
to third
later,
week.
so not in the first week, right? Okay, fine. So you gave IVIG at what stage?
On the fourth day of the illness. So as soon as the MRI brain and NC were negative and clinically we were suspecting polyneurosis cranialis, we started on the day of illness 4 IVIG was started.
Okay. One Dr. KF is asking, can you tell us how much time did it take for recovery? Over how many days he recovered?
He is still recovering. It usually takes the limit for GBS it is
No,
4.
when have you given IVIG? How many days back?
Last week only, sir. 4 week on 4th day of illness. Today it is probably 10th or 12th day of illness actually.
So 6th, 7th day after IVIG.
Yes. Today is post 1 week probably.
Okay. Fine. Anything else? Any other questions? So what do you think is the prognosis for this child?
There can be complete recovery also with as seen in GBS there will be 4 weeks of symptom, 4 weeks of plateau and 4 weeks of recovery.
Okay. Mahesh is asking, he had bulbar weakness. Which patient you will give airway protection?
If it is severe enough that he
We'll observe for single breath counts if they are less than 10 and absent gag reflex or weakening of gag reflex. Then we'll give airway protection.
Single breath count is a measure of the 9/10th respiratory muscle. So that's about the respiratory muscles, and your gag reflex is about your risk of aspiration. Okay. Fine. I I think we'll stop here this case. Yeah, very well presented. Good, thank you. We move on to the second case for today.
Good evening, everyone. I am Dr. Gokulan, second year resident in Sain Hospital. My case is a 2 years, 2 months old boy, first by birth order, born by non-consanguineous marriage, resident of Govandi, hailing from Uttar Pradesh, Muslim by religion, Sheikh by community, brought by mother with chief complaints of loose stool since 8 months of age. Case history: child was alright till 8 months of age, then he developed loose stools, 7 to 8 times per day, semi-solid to water in consistency, foul smelling, sticky, large quantity, stool were oily and greasy, at times passing undigested food particles associated with abdominal pain, more in periumbilical region, that aching, radiating, not associated with food intake. Native history: no history of blood in stools, no history of worms in stools, no history of fevers and recurrent infections, no history of lethargy, no history of Cox contact, history of not gaining weight, no history of burning maturation. Past history: history of previous 2 admissions in the past. At 3 months of age, in view of LRTI, IV medications were given, no O2 requirement, discharged on oral medications. At 8 months of age, in view of AG with dehydration for 7 days, conservatively managed. Child has many OPD visits for the similar complaint for last 1 year. Multiple investigations were done, multiple antibiotics and deworming were received. Antenatal history was uneventful. Birth history: full term, normal vaginal delivery. Cried immediately after birth. No history of NICU stay. Birth weight 2.6 kg. Immunization history: immunized date, developmentally appropriate for the age. Dietary history: exclusively breastfed till 6 months of age. Complementary feeding started at 6 months of age with dal, khichdi, fruits. Now child is currently on 1 egg in morning and khichdi 3 to 4 times per day. Non-veg diet and fruits. Non-veg diet and fruits stopped since 2 months. Impression:
Okay, so what is your first impression from this history? What are your thoughts? No, go to the second slide, yeah. 7 to 8 times per day, semi-solid to watery, foul smelling, sticky, large quantity. Stools were oily and greasy. Malabsorption, okay, of what? Fat malabsorption. Okay. Now this fat malabsorption has started at 8 months. How will you confirm that? What history will you ask? No, so basically you have to ask whether this child was absolutely alright before this in terms of growth. You heard that this child was started on food at 6 months of age, and till before that exclusively breastfed. So you need to confirm whether in the first 6 months of breastfeeding this child was absolutely alright in terms of growth or not. So what do you think, history wise?
Sir, so, according to mother, he was absolutely normal till 6 to 8 months of age.
Growing well.
Growing well, yes. Sir.
Okay. And when so the second thing is that 6 months the complementary food was started.
Yes, sir. At 6
and
months
the
of age.
diarrhea started at 8 months, not at 6
No,
months.
sir. No, sir.
Not after the
Not
starting of
yes,
complementary
yes,
food, right?
Yes, sir.
Okay. Now you also mentioned that the child was admitted at this time for a
third month of
acute
age.
gastroenteritis. So was that the first illness or the first manifestation of this whole diarrhea?
Yes, sir. At 8 months of age, he was first admitted for diarrhea, sir. Before that, he was admitted for LRTA.
No, correct. So till he was admitted for that diarrhea at 8 months of age, prior to that he had no diarrhea.
No, sir.
Correct?
Yes, sir.
So the starting point of this whole illness was an acute episode of diarrhea.
Yes, sir.
Correct?
Yes, sir.
So what does that tell you? Are you trying to get what I'm driving at? What does that tell you? So any malabsorption will not come as a acute episode of first. So if this history is correct and it did start with an acute episode which necessitated admission, probably for dehydration, which means that that was a infective diarrhea, even rotaviral for that matter, and then the whole sequence has started after that. So after an acute episode of diarrhea, what all can go wrong?
Secondary lactase deficiency due to shedding of all mucosa. UTI.
So should you feed a child during diarrhea or should you not feed during diarrhea? Should you give food or not give food? You should give food, but most or at least half the community thinks that in diarrhea you don't give food. So what happens during an acute diarrhea is wrong beliefs and practices. They don't feed or they withhold nutrition, the child becomes weak, the child doesn't recover from that acute episode, the epithelium keeps getting denuded. We read that he has got multiple antibiotics, etc. So you can land up with a vicious cycle following an acute episode of diarrhea, and that also can beget malabsorption. So you have to be sort of try to dig into the history whether it started with an acute event or it was a gradual process over a period of time. True malabsorption will not start one day with an acute event kind of a thing, right?
Yes.
Okay. Then any comment on this pain more in the periumbilical region, etc., what that description is? What are your thoughts? Okay, it might be bloating. What else? What other thoughts? My first thought was, will a 8-month-old, at that time he was 8-month-old, right? Will he be able to say where the pain is? Right? So you have to think all this. So this could be the mother's perception. Mother always feels that, it's a abdominal disease or abdominal problem. So she thinks that there is pain there. So it has no localizing value. Now, history of not gaining weight is since when?
Since 1 year of age.
Since 1 year of age. Do they have any records?
Matlab, anthropometrically child is Sam, sir.
Okay, no, but earlier you don't have any obvious records to know when the lack of weight gain started?
No, sir.
No. Okay, fine. So now, and then there's nothing else in the history, right, after this? Yeah. So now what are your thoughts? We started off by saying fat malabsorption. So what are the causes of fat malabsorption? Cystic fibrosis? Yes? So all of you agree this could be cystic fibrosis?
It will present with failure to thrive and recurrent lower respiratory tract infection rather than just as a diarrhea.
No history of recurrent LRT, only one admission for LRT.
So what was that one admission? Any details of that 3-month-old admission on history? See, it is my request to you that whenever you get any child who gives you a history of admission for a LRTI or a pneumonia, please ask the history in details. Forget the papers, forget the records, whether they are available, not available. Ask the history, what happened to the child, why did you go to the doctor? Okay? Now, what are the big things that you have to pick up from the history at this age? For any LRTI or pneumonia at 3 months of age? How do you decide that? Was it really a pneumonia?
It can be bronchiolitis or just...
You're right, it can be bronchiolitis. That's much more common at 3 months of age. So in your history, what do you want to ask?
Was the child sick or he was playful?
First question is fever. Whether the child had fever at that time, how high was the fever? That is one important question. Second is breathlessness. Whether was the child breathless? Okay? And then relative to everything, cough, etc., how long was the child admitted? When did he get better? What treatment was given? So these infancy history of pneumonia and history of admitted for LRTI are all very tricky. So make it a habit to make your own judgment whether it was genuinely a infective thing or a bronchiolitis or a reactive airway disease or a aspiration or whatever at 3 months or a cardiac event. So make your own judgment, right? So here we don't know the details about that 3-month thing, right? Okay. So you're right that in our Indian population, cystic fibrosis coming with isolated GI malabsorption without prominent respiratory complaints is very uncommon. So we wouldn't think of that. What else as a cause of fat malabsorption? Could it be chronic giardiasis? Foul smelling stools, large quantity. Come on, thoughts? So, if the weight gain is very poor, then that is a strong point against, no? So why should a child have chronic giardiasis at this age, which lasts for 1.5 years? It's very unlikely and contributing to persistent poor growth, right? Okay. So could it be, could it be a genetic fat malabsorption, some genetic enzyme deficiency?
We start earlier, मतलब Kanchan, I think.
Okay, should start earlier. And
The child should have not grown only in the first. He should not have grown well in the first 6 to 8 months.
that's not kind of a rule, because it also depends on the severity of the defect and things like that. But what is one difference between inflammatory malabsorption and genetic enzyme deficiency causing malabsorption? One big clinical difference. Other systemic features, anything else? So if I ask you what are the symptoms of chronic inflammation, my question is, what are the symptoms of chronic inflammation? Chronic, not acute. What are the symptoms?
Low grade fever.
Low grade fever, then
Anemia, pallor.
symptom, pallor, then
Fatigue. Weight loss,
then
not gaining weight.
not gaining weight. Why not gaining weight? So lack of appetite. Na? Loss of appetite is one of the important symptoms of chronic inflammation.
So vitamin deficiency.
So in genetic enzyme deficiency malabsorption, they are ravenous eaters. They don't have a loss of appetite because there's no inflammation. So they are eating, but they are not absorbing, so they are passing stools and losing all the nutrition. But there's no problem in appetite. Whereas in inflammatory causes, there is a lack of appetite, right? So this child, how was it? Appetite-wise, you asked?
Appetite was good, sir. Appetite was good, sir. Child was.
Appetite is good.
Appetite is good.
All through. Means, yeah, okay. So appetite is good. So now that favors a non-inflammatory cause. So the one which I was postulating, acute onset GI infection followed by a vicious cycle of wrong food causing further malnutrition, etc. In that, will the appetite be good or bad? Bad. So if this appetite is good, then it goes in favor of a actual malabsorption due to some enzyme deficiency, right? Okay.
Not in this case, but when parents bring the child, small child, for a more barber because they ask them whether, especially breastfeeding, that physiological also, because these children keep on passing small amount of stool every now and then. The count of stool goes up, but a child is happy. All that you have to do is take care of the bottom because it becomes red. Not applicable here. Now this child particularly was breastfed till 6 months and started at 8 months, and there was significant diarrhea, there was no doubt. From 8 months till now this child has diarrhea. So one is, where is the pathology? Is it in the small intestine or is it in the large intestine? Now what is the characteristic of small intestinal diarrhea and large intestinal diarrhea? Yes. Small intestine is large volume, and in the large intestine, small volume and tenesmus. Often pain is a very important symptom. Also the pain localized to umbilicus is less common because umbilical localization often says that it is a small intestinal problem because It's a visceral pain and a referred pain, and a visceral pain depends upon the supply of the peritoneum which it is covering. So often periumbilical pain. So this is probably, and not small, sticky, with blood often. For example, ulcerative colitis, often they have blood in the stool. So this looks like a small intestinal disease. Then you come to a cause, either it is inflammatory, parasitic, or it is a non-inflammatory cause. And as it was discussed, whether it is inflammatory, appetite is maintained of the child passes stool and is hungry again, suggests that there is not too much of a inflammation. So pain, fever, loss of appetite, and general health tells you that there is inflammation. It has acute symptoms and it has chronic, slow progress, subtle symptoms that he has. And a large intestinal diarrhea is that we saw. So this probably has small intestinal diarrhea. Inflammatory or malabsorption, we don't know, because both will give rise to significant loss or failure to gain. But a preserved appetite favors malabsorption, and a reduced appetite presents as inflammatory disease. So this is how we come to probably non-absorption, small intestinal diarrhea, giardiasis and worm infestations are all ruled out nowadays. They don't occur and will not go on for long. And then you think of other causes like presence of and absence of low-grade fever. In chronic inflammation, constitutional symptoms are subtle. So unless you make inquiry, you may miss on that. So all these things are often probably non-inflammatory, but we'll be a little wiser here. Also as the history of consanguinity, because consanguinity may favor metabolic diseases over an inflammatory disease. So this is how.
Can this be HIV or immunodeficiency, one respiratory illness and now chronic diarrhea? What do you think?
For a primary immunodeficiency, again, he was okay till 8 months and then the manifestations have started. So that may not be very likely, but 3 months. So that was just one illness. Until 6 months, apparently he was thriving well. But for HIV, we can't rule out. It is possible.
Yeah, so again the details are important. So that 3-month illness, how did it get better? If there's an immunodeficiency child, he wouldn't get better quickly. So first of all, as we said, we have to decide whether it was infection at all. History sounded like that. And then did it take time to get better types? And then again this point of appetite. So this is very important in the history, but if appetite is well maintained, then even any immunodeficiency causing chronic diarrhea is ruled out, because there it is an inflammatory process, right?
And multi-system involvement. Here there is only one system primarily involved. The first episode of respiratory, this word LRI is very confusing. It conceals more than it reveals. But did it start with fever, and was the child breathless? Was he given what treatment? How many days is discharged? So far in last almost 2 years, 1 year and 2 months, only one system is affected. There has been no evidence. So generalized immunodeficiency probably is not that it's a small child. So immunodeficiency comes little lower and metabolic will come again higher.
So Dr. Palniraman is suggesting, when we discussed immunodeficiency, Shakman-Diamond syndrome with neutropenia with pancreatic insufficiency. So it's because of the fat malabsorption that he's suggesting that if you are thinking of immunodeficiency, think of that. But we've discussed that there are some reasons which don't seem to fit in. Go on.
Past history, history of previous to admission.
Yeah, you've told us this. Go ahead. Go ahead.
Dietary history.
Yeah. So So dietary history we want in a little more details. You said now child is on one egg and khichdi, but what about this whole 1 year when this child has been having loose motions?
Sir, she's on regular diet, dal, khichdi, fruits.
She's eating everything.
Eating everything, non-veg, everything.
So all along this child has been eating well.
Yes, sir.
Right?
Yes, sir.
Okay. So I think that strongly favors a
non-inflammatory
yeah.
cause.
Okay. Go ahead.
Impression. 2.4 years, male child, first by birth order, born by non-consanguine marriage, with chronic diarrhea with sticky stools, probably a case of chronic small bowel diarrhea rather than large bowel diarrhea with malabsorption.
So what are the possible causes at this stage?
Sir, celiac disease.
Celiac disease, okay. Why do you think celiac disease?
Small bowel,
Okay.
large quantity, fatty diarrhea.
Okay. Fine. Go ahead.
General examination. Afebrile, pulse rate.
Child is here?
No, sir. No, sir.
No.
Afebrile, pulse rate 128 beats per minute. Respiratory rate 26 cycles per minute. Peripheral pulse well felt. Saturation maintained. Oral mucosa moist. Skin pinch normal. Eyes normal. No signs of any dehydration. Head-to-toe examination. Head minimal frontoparietal bossing. Eyes, nose, mouth normal. No dysmorphic faces. Hair light color, thin. Chest abdomen normal. Spine, back normal. Genitalia normal. Anthropometry 8 kg less than -3 standard deviation. Height 75 centimeters less than -3 standard deviation. Mid upper arm circumference 11.5 centimeters less than -3 standard deviation. Hip circumference 46 centimeters -2 to -1 standard deviation. Weight for height -3 standard deviation. Impression. Sam.
Will you comment on the weight for height? 75 centimeters is the height of a what age child?
2 years.
You people
6
carry,
months.
you do well baby checkup very regularly. No, one of the clinics, well baby checkup means you see hundreds of babies. So even if you don't want to remember, invariably you will remember that 6 months old child is this much and 1 year child is this much, even if you don't remember. So 175 is what? 50 is birth, 75 is 1 year if it's a good height. Now suppose this child's height age is 1 year and his weight is 8 kilo. So how is he for a 1-year-old child grown? Not too bad. Isn't that so? He has more of a short stature, but for that given stature, his weight is not that bad. Okay.
So you remember in second, third standard of school, teacher used to say repeat. 2 2s are 4, and we used to repeat, right? So now from next time I think we will start the class and end the class with 6 months length is 68 centimeters. 1 year length is 75 centimeters. We'll start the class with this, end the class with this repetition. Agreed? Or you'll learn today and never forget it from next Thursday. Okay? Please. Today all of you will not eat dinner till you have mugged up the height and weight up to 5 years.
You eat together, no? Or no, at least dinner. So you have all those, during dinner, all those talks going on in your, this fellow is, this teacher is good, this not. In that you can tell me 1-year-old height, tell me what is the milestone of a 6-month-old baby, how to distinguish 3-month baby from 4th-month baby, only on examination from milestone. So it goes on to and fro, and you enjoy also. The food also will be more tasty.
So now I want to ask you again one more question, but that is only if you understand all these height, weight. So looking at this anthropometry, if you didn't know the history, Can you say when did this child's problem start?
7 to 8 months probably. So his height age and weight age roughly correspond to 10 to 12 months. So it must have started approximately maybe.
Means you need to fine tune your answer. Your answer is right. 75 is at what age? Sir? 1 year. And 8 kg is at? In a child who is born normally. 9 months. So first of all, there is a difference between the weight age and the height age. This child is 2 years plus, right?
Yes, sir. 2 years, 2 months.
2 years, 2 months. So this is a 2-year, 2-month-old child whose height is like a 1-year-old and weight is like a 9-month-old. So is height affected? Yes. Is weight affected? Both are affected. Weight is affected more than height. This pattern is a pattern of dash or dash. Chronic malnutrition or chronic systemic disease. Okay, this should be in block letters in your brain. Okay, so first you have to identify this pattern. Now you have to decide with your history and all, okay, is it chronic malnutrition or is it chronic systemic disease? Older the child, more likely it is chronic systemic disease. In a younger child, both are possible, right? So here, in this child, if they are telling us that this child is eating everything, all food, everything, all throughout 1 year, then there is no malnutrition, there is no primary malnutrition. So this is chronic systemic disease, right? Now your answer of when it started, you're right that it started in between 6 months to 12 months, but why? Give a more solid reason. No. Looking at the anthropometry. Very good.
Growth is maximum at the first year, so 75 centimeter he has achieved. So first year was not so bad. It started in between that.
So he has achieved 75, that means till 1 year he was fine. Then he achieved 75, then the button got switched off. No. Gone.
To manifest at 1 year of age, it should have started somewhere 3 to 4 months before.
See, all of you are there, but you are not able to express it. If he has achieved 75 centimeters, within that 1 year, when is the growth fastest? First 6 months or second 6 months? First 6 months. So if he was affected in the first 6 months, then he wouldn't have reached 68 only in the first 6 months. So then he couldn't have reached 75 now, if his first 6 months ka growth only was affected. So because his first 6 months growth was not affected and second 6 months partially affected, so 68 mein se he must have become some 71 or 72 at about 1 year, and then in the second year further affected. Out of the 12 that he was supposed to gain, he gained 3 or 4, something like that. So this is the way you have to estimate. So because he has reached 75, it is likely that he started just after 6 months, but not before 6 months. Before 6 months it would have been worse, right? Same is true of the weight. So it corroborates with the history that he was normal till 6 months or 8 months and then started, right? Okay, go on.
Parabdominal examination, inspection, globular, all 4 quadrants moves equally with respiration, no localized bulge, scars or dilated veins, umbilical centrally placed. Palpation, no tenderness, no organomegaly. Percussion, tympanic note, auscultation, normal bowel sounds here. Impression 2.4-year male child, first by birth order, born by non-consanguineous marriage with chronic diarrhea with sticky stools, probably a case of inflammatory bowel syndrome, celiac disease, intestinal TB.
So what do you mean by inflammatory bowel syndrome? Means are we talking of inflammatory bowel disease like ulcerative colitis and Crohn's?
Yes, sir.
Okay, why did you put that as the first diagnosis?
Sir,
You can just discuss your reasons. We are not, you are a young student, you are junior, we are not expecting you to be, we just want to discuss the reasons. So why did you put that first?
sir, small bowel diarrhea.
Okay.
Matlab,
Small bowel diarrhea, agreed.
malabsorption with
Malabsorption, yes. So now, if we have to discuss the key features of inflammatory bowel disease, start listing the key features of inflammatory bowel disease. Forget this child. What would you want as the first feature of inflammatory bowel disease? Diarrhea with blood and mucus. So in fact, you don't even say mucus and blood. You say blood and mucus, which means blood is something which you want. This child has blood? No. Okay. Next, what do you want in inflammatory bowel disease? Okay, loss of appetite. Here there is a good appetite. Third, pain. Okay, pain is a prominent feature. So in this 2-year-old, when mother said abdominal pain or around that periumbilical whatever, you need to dig and ask that is this child irritable, crying, how often is that pain, how genuine is that pain?
Sir, whenever he passes the stools, he have a pain.
Okay, so he has a pain every time he passes a stool.
Frequently, not every time.
Okay. Now, just for learning, how do you dissect this history? Suppose mother says, "Jab bhi stool karta hai, rota hai." Can this history also be further dissected?
Is he crying before passing stool and comfortable after passing? Then it is normal.
Okay. Anything else? Can you get this history in a rotaviral diarrhea?
Because
जब
of
भी
crampy
motion करता है
abdominal
रोता
pain.
है.
Because of the excessive gut movement and crampy pain can be there.
Okay. Any other reason? Very good. Perianal excoriation, and that stings and burns. So the subtle difference is, as sir said, whether this pain or crying is a feature of tenesmus or it is that after passing the stool it is stinging and burning him because there is excoriation. So all these small differences also you try and make out in these histories. Okay? Fine. Now, what is a common age for inflammatory bowel disease? In general, older child. Okay, older child, adolescent. So infantile inflammatory bowel disease is known, but not very common, right? Okay, then what else do you want in that story?
It would be a sick-looking child, inflammatory bowel disease.
Okay, then there could be fevers, right? And then there's not a continuous story over 14, 15 months. There are exacerbations and remissions type, right? So all those things we need to differentiate. Then what about celiac disease? Points for, points against.
It has started 2 months after the introduction of complementary feeding.
Okay, so how strong is that point against? Can celiac disease start at 2-3 years? Can it start at 5 years? Can it start at 10 years? Can start any time. So that alone is not like a make or break point. Okay, then what else? So again that appetite point becomes important. So if this is celiac disease which is so florid that it has come as a florid diarrhea for 1 year and led to sort of growth failure and all, then there is a fair degree of inflammation. So then this child is not expected to have a good appetite. Secondly, if that greasy oily stool is to be believed, then that is also a little unusual for celiac disease, right? Okay. What about intestinal TB?
It would rather present with symptoms of obstruction, like subacute or...
Excellent. Why? You're right. Now give me the reason behind that.
Sir, mainly it involves ileocecal
junction. Site of involvement is ileocecal junction commonly. So.
Okay, so ileocecal junction is in the, when you're talking of the length of the intestine. Any other reason?
It will cause stricture formation.
Why? Very good. Why?
Ulcers.
So it involves the submucosal layer of the intestinal wall, whereas diarrhea is a mucosal symptom. Something is wrong with the mucosa. So in celiac disease or in malabsorption, it's the mucosa which is not able to absorb. That is why you're getting diarrhea, right? So there should be symptoms of stricture or obstruction off and on types, right? So that is why that is also less likely. Fine. Tell us the investigations.
CBC total counts 12,000, hemoglobin 10 gram, hematocrit 32%, platelets 1,92,000, MCV 83.8, MCHC 31.2, VVG pH 7.3, bicarbonate 21.1, PCO2 38.3, tissue transglutaminase IgA 2.37 negative, USG abdomen NAD, no abnormalities, fecal calprotectin, report have to be come.
Okay. So from this, what do you make out? What about the differentials? Is there any neutropenia as was suggested from the chat?
So
nothing.
Nothing.
Okay. So what do you make out from this?
Could be no anemia, sir.
No chronic anemia.
No chronic, no features of anemia.
Okay. So 10 is on the lower side, but yeah, okay. Then TTG is negative, so your screening test for celiac is negative.
Yes, sir.
Okay. So what next now? You do anything else you are doing? How are you managing this child?
Sir, currently we are providing gluten-free diet, suspected celiac.
Okay. So you started on a gluten-free diet.
Yes, sir.
When did you start?
Sir, before 1 week. Before 1 week.
So you've seen any change?
No, sir. Still now he is having diarrhea.
Okay. You've done a stool routine to see whether there is a lot of fat excretion, or how is it?
Yes, the stool routine was done previously, 1 month before. There was a fat in the stools. Fat in the stools, and helminth eggs were found in the stools. Helminth eggs.
Helminth eggs were found.
Yes, sir.
Okay.
Yeah, 1 or 2 points. When you think of tuberculosis or intestinal infection, you remember pain, inflammation, caloric, molar, all those things. They are there, but in a low grade. So diagnosing of inflammatory bowel disease in the absence of pain and general ill health is difficult. Now, many of our IBDs and inflammatory bowel disease or inflammatory becomes a DVD of irritable bowel syndrome. So both present with pain, and they come to us mainly for recurrent abdominal pain with or without that. So pain is and low grade fever. The absence of that inflammation, tuberculosis, whatever, is less likely, and we come back to metabolic. There's some deviation when doctor mentioned about Palniraman mentioned about pancreatic. Now in this part of country we don't see much of pancreatic problem, but in Kerala and lower Karnataka they do see pancreatic diarrhea. They see recurrent pancreatitis giving rise to pancreatic atrophy, and in South Maharashtra and that area one has presented 20 to 30 cases of chronic pancreatitis resulting later on in shrinkage of pancreas with calcification and chronic diarrhea. They do come with recurrent abdominal pain, diarrhea, which we often don't think of a pancreatic diarrhea. And one of the tests that we used to do is that if a child is malnourished and has diarrhea, we used to take an X-ray of upper abdomen. At that time sonography was not there. Upper abdomen, sometimes we used to see calcification as a result of chronic pancreatitis. So though not common in this, because we don't often entertain pancreatitis as a common entity in our side. So keep that in mind. So pancreatitis is also, though not in this case.
So Dr. Palniraman has said that toddler's diarrhea is an important differential of chronic diarrhea, but with preserved appetite and growth normal. So here growth is affected, so we are not considering that. Means he's also said with growth normal, and in this child ideally we should be doing a endoscopy and biopsy. That would tell us all the, rule in, rule out various things. And he says chronic fibrocalcific pancreatitis is common in South India also. Okay, fine. So what else can you do in the management of this child while you await a diagnosis? Suppose it is fat malabsorption, then what can you do?
Addition of vitamins, fat soluble vitamins, enzyme replacement therapy, if adding MCT oil.
So addition of fat soluble vitamins is to counter the effect of those vitamins not getting absorbed because of fat malabsorption. But to treat the basic fat malabsorption, if you try adding MCT, then you are bypassing some steps in the digestion, right? So that might help in seeing whether the diarrhea stops and whether there is weight gain.
So
right?
Can we add pancreatic enzymes?
Can you add pancreatic enzymes? I don't know how much it will help, because it has to, once it goes through the gastric acid and all, it will all get denatured. So I doubt whether it will really help, right? And one more thing I was saying. In this 7 days that you have started with gluten free, any change in the weight also that you have not observed? I was saying, can you do fecal fat excretion? Can you weigh that, and can get a quantitative estimation of fecal fat excretion? Is it possible here or no?
It's not possible.
Okay. Okay.
Pallor is a very significant point in celiac disease. All our short stature and pallor, all are anemic. This particular child, 10 grams, is not normal, but not the way we would, 6, 7 grams, I would have expected.
Any other questions? Yeah.
So TTG IgA we usually should compare with serum IgA, especially since we are thinking we mentioned primary immunodeficiency. So.
Yeah. So she's made a point that if for some reason if serum IgA is itself absent, then you will get TTG IgA falsely negative, right? Okay.
Sir, and about immunocompromised state, means are we completely ruling that out? HIV. Means again,
I mean, I wouldn't say completely ruling it out, but as I said earlier, if this child, I mean, we constantly got a message that this child has a very good appetite and is eating well. That is my strong point against, right? Obviously, you would do HIV because then you would easily treat this child, but then that's a strong point against.
Microcephaly. What's the head circumference? If it is congenital, how much is that? Huh?
-2 to -1 standard deviation.
46.
46. Minus.
Yeah.
Okay, so I think we'll stop here. Thank you very much, Dr. Gokulan, for that second case. So we'll quickly summarize today's two cases. So the first child was a very healthy child who suddenly started with symptoms suggestive of one-sided sixth nerve palsy, quickly followed by other cranial nerves, which included the other side sixth nerve, the third nerve, the ninth and 10th, all over a span of a few days. So our discussion was that when it first came as a sixth nerve, we wondered whether it is that rare situation where sixth nerve is a false localizing sign and there are no antecedent symptoms of raised ICP, which itself is very uncommon. But the moment the second and the third cranial nerve came, that thought process was abandoned. Definitely it was not raised ICP, and because all these nerves, their nuclei are situated far apart, it could not have been a structural lesion which is affecting all of them. So again, SOL or those things were ruled out, and therefore there was no fever. So this was unlikely acute inflammation also, unlikely any vascular phenomenon because there was no other cranial neurological areas getting involved. So this was something that was specifically happening to nerves, which zeroed it down to a demyelination process, and then we thought of a acute demyelination process, something like a GBS equivalent, whether it was a first manifestation of ADEM or a variant of GBS, etc. And then it did turn out to be a demyelinating process and the child responded to IVIG. The second child is a 2-year-old child who was absolutely normal for the first 6 months when exclusively breastfed. Complementary food started at 6 months properly, and then from 8 months prolonged diarrhea till the age of 2 years, which is in the form of 7 to 8 stools with fatty, greasy stools and failure to thrive. So obviously there is fat malabsorption. We discussed that it's unlikely to be cystic fibrosis, etc., because there are no respiratory manifestations. We discussed that appetite is well maintained, which points more to a genetic cause of malabsorption of a enzyme being deficient rather than a inflammatory process. And we discussed why this is less likely to be inflammatory bowel disease or celiac disease or intestinal TB. Let's await for the final diagnosis next time if we can get some feedback on this child. So with that, yes sir. So with that, you have any inputs on the earlier cases? We had that 3-month-old with multiple lymph nodes. Any diagnosis was arrived in that child? We had to send the multiple lymph nodes for biopsy. We were suspecting some primary immunodeficiency. Okay, just find that out and let us know next time. Okay, fine. So with that, we stop today's class. So we thank you once again, all the online viewers, online faculty, online students who are watching, and the students here. And we once again thank Aristo Pharma for their educational grant to help this live webcast. We meet once again next Thursday at 6 p.m. Thank you.